How's it going today, guys? It's Jack from Dose of Pharma, your host. I'm joined today by Nikhil Singh, pharmacist from Peter Mac, as well as Associate Professor, Cornelia Landersdorfer. And we're going to have a bit of a chat about infectious diseases today and all things ID. So how about we launch straight into it? Maybe you can do a little bit of an introduction of one another. Maybe Cornelia, you'll go after Nikhil. Mm-hmm. So how about you?
My name's Nikhil. I'm a pharmacist at the Peter MacCallum Cancer Centre, where I wear, two main hats. So I'm the Antimicrobial Stewardship pharmacist there, as well as a research pharmacist based out of the National Centre of Infections and Cancer, which is also located in Peter Mac.
Wonderful. What about yourself, Cornelia?
Yeah, thank you. I'm a research group leader here in the D4 theme, which is drug delivery, disposition and dynamics. And there we've got a microbiological laboratory where we do experimental studies, and then we also do a lot of mathematical modeling. I'm also currently the scientific director of the Monash Moderna Quantitative Pharmacology Accelerator, which is also a mathematical modeling project, and I teach in the Pharmaceutical Sciences course here.
Wonderful. Feels like we've almost got a bit of a full spectrum of the infectious diseases team here, because we've got the baseline research of our PK/PD, the application in the pharmacy and the hospitals itself, as well as a bit of research, and the student who's completely naive to everything at the moment. So I suppose, curious as a student, what kind of got us interested in infectious diseases? So maybe Nikhil, do you want to start?
Yeah, I'm going to paraphrase from a conference I went to earlier this year where eminent infectious diseases pharmacist Erin McCreary spoke and said something that really sort of resonated with me. So essentially what she said was that if we think about maybe other specialties where cardiology, where there's someone who has an arrhythmia and then you want to give a drug and slow that heart rate down, there's sort of two things that are happening. There's the patient and there's the drug, and there's the way that the drug interacts with the patient, which is pharmacodynamics, and then the other way around, which would be pharmacokinetics. But what makes ID, I think, special is that there's a third party involved, right? So there's not just drug patient, there's bug. And the bug can interact with the drug, and the drug can interact with the bug through, free pharmacodynamics and antimicrobial resistance mechanisms. Then you've also got how the bug interacts with the patient through infection and also immunity, so the other way around. And there's the sort of the interplay between the three, which I think is very interesting. And as you touched on earlier, there's a whole lab side of things, which I think Cornelia can speak to. But
Yeah, I personally appreciate managing these complex patients. And like you said, cardiology, you got the patient, you got the drug, but then microbiology, infectious diseases, you're bringing in the bug. That's a whole other ball game, especially with the emergence of things like antimicrobial resistance. I might even pitch that as introducing a fourth factor. Hey.
Yeah, exactly.
I'm curious, Cornelia, what got you into infectious diseases research?
Yeah, I was at the same talk as Nikhil just talked about, where Erin explained this. Yeah. And I completely agree. And just, from the lab side, actually also the interesting thing is that we can take the bug out of the patient and we can investigate the interaction between the bug and the drug in the lab. And then we can get data from clinicians like yourself about drug concentrations in patients and effects in patients, and we can build our mathematical models in order to describe these interactions you've spoken about, in order to then feed back to the clinicians and work with clinicians how we can use this research to actually optimize the dosing for patients.
Wow, that's actually quite exciting. To see the use of mathematics, because, going through high school, I would never have thought of connecting mathematics with patient care. So personally, that's quite exciting to hear, and we're only just getting started. Now, talking about pharmacokinetics, pharmacodynamics, for our listeners that may not be familiar with the classic PK/PD, do you want to give us a little bit of a brief summary? What is it?
Sure. So pharmacokinetics, it's often described as what the body does to the drug. So basically it's about someone taking a dose of a drug, and then it describes how drug might get absorbed if it's from a tablet, distributed in the body and eliminated. So basically it describes the relationship between the dose or dosing regimen of a drug and the concentration time profiles that we see in the human body. Okay. So that's pharmacokinetics.
Yep. Okay.
And then pharmacodynamics is then describing the relationship between those drug concentrations in the body and the effect that they have in the case of antibiotics or other antimicrobials on the bug.
Yep.
Which is the therapeutic effect that we want, but then also there might be a risk of toxicity, which is an effect on the patient.
Okay.
And the reason why pharmacokinetics and pharmacodynamics are important to understand is that making this connection between the dosing regimen of a drug and the therapeutic outcome, if we understand that, we can basically then find out how do we need to optimize a dosing regimen for particular patients in order to help clinicians optimize doses.
Okay. I wish I had your explanations in my lectures. I'm not going to lie. It's a bit more clear to me now, even as a fourth-year student, what pharmacokinetics and dynamics actually means specifically in the use of antimicrobials. But now I've got a question itching in the back of my head: is what might be a real-life example? Maybe Nikhil, you can touch on that of PKPD.
I think there's a few examples that I can think of. So I think maybe last year there was a big trial published called the Bling3 study, which had Jason Roberts, ID pharmacist from Queensland, sort of his study group led. And they looked at sort of a very simple idea of just infusing meropenem or piperacillin tazobactam as a continuous infusion versus what we normally do, which is just sort of intermittent doses throughout the day. And they did find, even though it was very close but not quite statistically significant, a 2% reduction in mortality, which doesn't sound like much on face value, but in today's era of medicine, where we're very good at keeping patients alive in a critical care environment, that kind of reduction in mortality is something that is probably viewed clinically as quite significant. So I think that's one example of just a simple PK/PD application that has resulted in sort of clinical improved outcomes in patients. And the other example that's quite topical at the moment is using vancomycin AUC monitoring. So sort of precision dosing using sort of dosing software mathematics, so Cornelia's wheelhouse, to really provide patients with, I guess, optimized doses of vancomycin, avoiding toxicity really, rather than achieving efficacy. But that has been shown in multiple studies to reduce AKI risk, acute kidney injury risk.
I was going to say the vancomycin really tanks the kidneys, hey?
Yes, definitely can. So.
Thank you for that. And I suppose maybe, Cornelia, from your lab expertise, maybe you can provide perhaps more a lab-focused example of when you might be using PK/PD briefly. For example, in one of your bits of research, I know you've been doing some work with meropenem as well, so maybe you can touch on that.
Yes, and that again fits with the first example that Nikhil gave, because we also worked with Jason Roberts, Jeff Lipman, who are investigators there in UQ. And with an example of meropenem, we simulated in our lab studies what is the PK profile, the pharmacokinetic profile, or the concentrations of meropenem over time in the body of different types of patients. Okay. And one interesting patient group is when patients are critically ill and they are, for example, due to a trauma, then they can have overactive kidneys, which is called augmented renal clearance. And basically that's something that, the researchers in Queensland had been working on clinically for quite a while. Yeah. So then we basically got together and said, okay, can we see in the lab study where we can specifically investigate the interaction between the drug concentration time profile and the bug, whether, does the bug still get killed if we dose a patient with meropenem and that patient eliminates it much faster.
Yeah.
So basically, we looked at that in our lab studies, and we found, even the highest approved dosing regimen of meropenem basically didn't make much of a difference.
Wow.
In that case, just because it gets eliminated by the kidney so fast, and then the bacteria have the chance to grow back and maybe become resistant.
Yeah.
So that was very interesting, because then they also took that back to the clinic. And for example, Professor Lippmann talked about a case where, they had a patient with an augmented renal clearance, and then from all of their studies and also what we found in the models, they were able to use a higher dosing regimen.
Okay.
And then fortunately, we also got to meet that patient after recovery. So that's a very specific, on a patient level example.
That's a really good example, because I know the therapeutic guidelines, a tool I use a lot as a student, and I know a lot of practitioners use, recently updated a lot of their antibiotic guidelines. And a part of that was, having a bit more integrated use of the renal adjustment for just about all of the antimicrobials available in Australia. But I never really see anything about augmented renal clearance. So it's always one challenge I hope someone can teach me how to challenge once I go into practice. But personally, it's not something I've been educated on. So it's really good to hear that there are people doing that work. So, for example, when my generation of pharmacists step into practice, we might have some evidence to base our practice off. So thank you for that. And I suppose kind of jumping on top of that of talking about, unique patient groups and this kind of, as I just mentioned, the future research and future evidence we need. Maybe, Nikhil, you can speak on what's an area of future research you might be pitching towards ID. I know it's a bit of a broad question, isn't it? But I know you're completing your PhD at the moment, so maybe you can talk a bit about that.
Yeah, I guess this is not PhD related, but an area of PK/PD research I personally would like to see sort of investigated more, and I think it's already been done, but just to see a bit more of it, is defining toxicity thresholds, I think. So Cornelia's mentioned, these patients that, have augmented renal clearance, and we probably should be giving bigger doses, but just sort of maybe understanding how much we can do that. At what points do we need to pull back? And I think, a lot of work is going into that, but just seeing some more defined consensus thresholds would be fantastic. The other one that jumps to mind is sort of going back again to the mathematics, is model-informed precision dosing is becoming quite popular. So using dosing software to really accurately predict exposures of antimicrobials, and I guess maybe seeing the impact of that on clinical outcomes. Because I think we definitely know that looking at outcomes such as target attainment, that it is better, but does that then translate to improve patient care, I think is probably the next step of that.
Yeah, I'm thinking back to when I was at work last night, and I'm thinking, I had this whole conversation about, what's the max dose of something like buprenorphine, or what's the max dose of all these opioids, but never conversation about what's the max dose of the antibiotics that we're giving all our patients in the ICU and even the CSU ward. And so I think that's a really good point, because I don't think it's even something, at least personally, I'd think about going into practice yesterday, but now that you've mentioned it, I think, it's definitely something I want to be on the watch out for, is these max doses, especially when it does come to toxicity, because obviously it's something we consider in practice, but like you said, we don't have those defined thresholds yet. Yet. And I suppose, talking about practice, Nikhil, maybe you can talk a bit on more of what can a pharmacist actually contribute to management of infectious diseases? Because I personally haven't done any time in the infectious diseases wards or with the teams rather on any of my placements, which has been unfortunate because I love ID. So I've met all the AMS pharmacists but never been on the ward round. So where does the pharmacist step in?
Yeah, there's a lot. If I just focus maybe on infectious diseases clinical pharmacy rather than stewardship.
Yes.
So I guess like clinical knowledge would be the first thing. So clinical practices. So I think ID pharmacists are quite uniquely positioned as they know the microbiology side quite well, application of that, susceptibility testing, but then also the drugs very well. So we have a hand in choosing what regimens patients go on for a variety of different diseases, taking into account drug-drug interactions. When you think of drugs like HIV drugs, tuberculosis therapy, drug interactions are everywhere, and you're really relied upon to make those sort of clinical decisions with regards to what to do with that. And then monitoring wise, so looking at sort of laboratory parameters to monitor for clinical improvement, but also TDM, that's a really, really big one. Obviously a lot of antimicrobials require TDM, antifungals, vancomycin, aminoglycosides. So balancing that risk of, toxicity versus also achieving efficacious targets. And then there's the whole patient facing side of it as well. So the patient education, the counselling about adherence, again, thinking about HIV, TB, where you're often speaking to patients who are immigrants, might not have great health literacy. You're just absolutely critical in making sure that they understand what is going on and that they're on board with the treatment plan and even, things like HIV, which can be, even now, nowadays still stigmatized a little bit, walking patients through that. So there's a lot of different aspects, but those are probably the main ones.
Yeah. And I think you brought up a couple challenges there. And as soon as you mentioned the HIV drugs, I think it was only 2 or 3 days ago where they've actually started allowing members of the LGBTQI plus community to donate blood. And it's 2025. So I think I was going to ask a bit more around the challenges, but I think you've already highlighted some. And I suppose, Cornelia, maybe reflecting this into the laboratory side, do you have much conversations with clinicians about maybe some of the challenges that Nikhil's mentioned about, making sure the patients are on board with their therapy, and how do you take any of these considerations into your research at all?
Yes, so that's very important for us because, as mentioned before, the aim of our research is not only to find interesting things in the lab and making nice mathematical models, but it's really, to translate it to patients, and then that's the really rewarding part as well. So, yes, we've got a lot of collaborations with clinicians, which is in a range of ways. So one way is that we get bacterial isolates from clinicians, from actual patients, and then we study those in the lab to make sure that it's all relevant to the bugs that are actually out there. We also have clinicians on our projects basically advising on the types of regimens we are proposing, that they would be clinically practical.
Okay.
And I think that is an important part because, as you mentioned, if we can design, let's say, a very complicated dosing regimen, but that's not really practical either for like staff in the hospital to administer or for patients to stick to, because it means they have to take a lot of different things every day. So then we need to take that into consideration. So yes, I think that's very important to have these collaborations.
Yeah, I love to hear that you do take these things into consideration, because I recently did a pharmacy placement out in a lot of remote communities in Central Australia, particularly based out of Alice Springs. And the rule of word, one of the first things I learned in the week is you never dose something 4 times a day because they're not going to take it. So, and that was interesting because the first thing that came to my mind is I think they've just recently updated our first line agent for uncomplicated cystitis. So UTIs, nitrofurantoin, 4 times a day. No one's going to take that out there. So I'd love to hear that you're actually taking these patient considerations into your research, because it really shows that the laboratory work you're doing is not just your PK/PD. You actually are putting the patient first. And I think that's why we're all here today as well. We all do care in our professions. And as a young student, it's actually really nice to see. I'm getting all giddy now. But I suppose going back to these sort of things, the patient-facing care now. Maybe, Nikhil, you can talk a bit more on this next question, but can you give an example of an intervention that you've made or a colleague has made? One intervention. Sorry to put the shackles on you, but...
Oh, goodness, that is actually very hard. It's interventions are sort of something you do multiple times a day. Goodness, I'm a little bit stumped. I will say.
Do you have a very memorable one that really made a difference in a patient's life? I mean, working where you work?
Yeah. Look, one that comes to mind is so many, but would be like I have worked in critical care, so in ICU, and we had a patient quite unwell, was seizing, but also had fevers, so had been put on antibiotics. Continued had fevers while on sort of pip-tas, got escalated to meropenem, but unfortunately was also on sodium valproate. So there is an interaction there that is not well known, I would say, but for those who might not know, so meropenem stops the enterohepatic recirculation of valproate. So as soon as you start meropenem, your valproate concentrations sort of plummet, which can worsen seizures, as you can imagine. So that's sort of one interaction that I made aware to the ICU team, who had sort of no idea about that. They checked a valproate level only like 2 or 3 days into sort of meropenem therapy, and it was undetectable. Stopped the therapy, changed antibiotics, and then sort of monitored the patient for seizures, while letting the valproate get back up to sort of therapeutic concentrations. That's one that sort of comes to mind. But
well done. Just look away while I take notes real quick. Wow. I suppose, Nikhil, you do work primarily with immunocompromised patients. So I suppose for those listeners out there that might be, unawares, and maybe Cornelia, do you do any work with immunocompromised populations? Like you said, you've worked with some special populations like augmented renal function. So maybe we can have a bit of a discussion here for some of our listeners that might not be aware. Maybe we can each give a definition of what an immunocompromised patient is, especially looking at the pharmacy side, and then again, see if that differs at all from what you might see in the lab. And Nikhil, maybe do you want to start us off?
Yeah, that's complex because it's such a poorly defined term.
Yes.
It means something different to I think, everyone. There are some complexities, because I think the simple way to look at it is someone is immunosuppressed or not. And I think there's some very clear examples of one way or the other, like somebody who's receiving chemotherapy for leukemia is obviously immunosuppressed. Someone who is not is not. But what about the patient that's taking 5 milligrams of prednisolone? What about the patient who is on a very specific immunotherapy that really only inhibits maybe TNF alpha? Where do they sit on that spectrum? So I think we need to appreciate it as a spectrum rather than a yes/no. So really, I think I would define it as really any host who is on, not actually necessarily on an immunosuppressant, but anyone who has a inherited disorder that affects immune function, or is on a medication, or has an iatrogenic reason to be immunosuppressed. And there's just different severities of that. And depending on the severity, you're prone to different types of infection.
Yeah. I think I totally agree there that it really is a spectrum. Like you could have someone on your 5 milligrams of prednisolone, but you might then have someone with SCID, doesn't have an immune system at all. And maybe Cornelia, have you done any work looking at these immunocompromised patients? And I suppose from the lab perspective, how would you define an immunocompromised patient? Big question, I know, but I'm curious.
Yes, we've done work in different areas. So if you ask me about an example, I mean, it's a mathematical modeling example with clinical studies as an example I can give. And this was specifically patients with primary immunodeficiency.
Okay.
And there, it was a bit different, but what we were able to do is basically we were able to model data from those patients who are on their usual regimen of having to do these infusions of IgG. Mm-hmm. And then we were able to use the mathematical model from these patient studies in order to predict what would happen if they do the infusions less frequently, which is much more convenient for the patients. Yes. And then basically we were able to get the FDA approval, or rather the company was able to get the FDA approval and EMA approval for that more practical dosing regimen for the patient without having to do some multi-million-dollar studies. And then the patients who tried it, basically they decided to, keep going with it. So that's an example from the mathematical modeling side of things.
Wow.
Yeah.
That's well done. Oh my. And I suppose kind of moving forward and looking forward, being a student, for future pharmacists that want to go into infectious diseases, especially working with these immunocompromised hosts, especially host patients, whatever you want to call them, what do you kind of see? Maybe Nikhil, you can answer a bit better on this question. What do you see for pharmacists in specifically managing these populations across the board? Because personally, I think, like you said, I've really only had education in my pharmacy degree, at least, on the patients that are on the immunosuppressants, rather than those that are completely immunocompromised outside of HIV. So
I think there's a growing role for pharmacists in this area. I think traditionally you've had pharmacists that just work in ID, so they have the micro and antimicrobial PK/PD sort of knowledge, and then you've got pharmacists who just work in organ transplantation or hematology or solid or oncology. But then you're getting a new area of pharmacists who kind of have both of those things, and I guess you would call that an immunocompromised host pharmacist, yes. Which is a role that is being specifically sort of available now increasingly, whereas before maybe 10 years ago that probably didn't exist. So it is a growing area, and I've have colleagues who are in that area who are even subspecialising further. So for example, one subspecialising in CMV and antiviral stewardship, so to speak. So her PhD is focused on the impact of multidisciplinary CMV care. Wow. Whereas another one's doing antifungal stewardship. So so even within the ICH space, there's becoming sort of subspecialties, and I think a pharmacist will always be needed there because, like I touched on earlier, these are patients on many drugs, on many antimicrobials that are just thwart with drug-drug interactions, and so you do need that specialised knowledge. So I think it's a growing area, and there'll be more demand for pharmacists to sort of specialise in it.
Okay. That's a really good point you touch on, because I think it's the first time I've ever heard anyone say antiviral stewardship. Because where I work, it kind of just the antifungals and the antivirals, they all kind of lump under the antimicrobial stewardship, which it's technically correct, but you're right, the subspecialties, it's a really exciting time to be in pharmacy because I think we're starting to recognise that we do need and have people that have this really specific knowledge and are becoming recognised for it. And I think I'm reflecting now because I was in the United States, as I was telling both of you earlier, where I was lucky enough to spend a couple of days shadowing their infectious diseases consultancy group. But in that case, I was specifically following one of their PharmDs that only managed their immunocompromised patients. And some of the cases and the bugs I was seeing, I'm like, I'd never heard of or seen rotatorula before, but I have now. And that was an exciting time to be overseas where arguably you could say they're a bit more forward thinking in their pharmacy practice and their specializations, and exciting to see that you're reflective of that now with some of your colleagues looking at antifungal stewardship and antiviral stewardship, specifically in CMV as well. So yeah, I think it's a good point of reflection there. And I think talking on antimicrobial stewardship, I think we can all say that we know it really exists because of the emergence of antimicrobial resistance. I hope we can all agree there. So for some of our listeners that might not be aware of it, which would be really unfortunate, maybe, Nikhil, you can kind of give us a brief definition of antimicrobial resistance, and maybe both of you can give, I hate to say this, your favourite example.
Yeah, very happy to define it. I guess in a way, it's an intuitive sort of term. It's essentially the development of a mechanism from a bug, whether it be bacterial, viral, fungal, parasitic, a mechanism of resistance to an antimicrobial. I guess it's important to know that resistance comes in different forms. So I guess 3 buckets broadly. There's sort of inherited resistance, meaning that particular drug just never works for that particular pathogen due to maybe structural issues. Yeah. An example might be mycoplasma. So that's a bug that causes pneumonia. Amoxicillin or beta-lactams in general won't work because it doesn't have a cell wall, and that's where they need to work.
Yeah. Yep.
So that's an inherited resistance. Then you've got adaptive resistance. So that would mean a pathogen, it has the machinery or the genes to turn on and off its resistance depending on the environment it's in.
Wow.
So an example of that would be maybe producing a biofilm to protect yourself from antibiotics, which many bugs do. And then you've got, and this is probably what we generally think of resistance as, is acquired resistance. This is what we tend to worry about. So this is where, either the bug itself has a mutation within its own DNA that then results in a mechanism of resistance to a antimicrobial, or it is the sharing of resistance genes between different bugs. So that would be acquired, and that's what we worry about. And that's, your typical ESBLs, your carbapenem-resistant organisms. And just speaking of favourites, I do love gram-negative resistance. So I'd say a carbapenem-resistant gram-negative is probably my favourite bug. Yeah.
Yeah, I'm always terrified of some of that horizontal transmission in our patients. But maybe, Cornelia, do you have your favourite example of antimicrobial resistance?
Absolutely. It's exactly the same as Nikhil just said. Carbapenem-resistant gram-negatives are just so, good at being resistant and becoming more resistant. And, narrowing it down, I would say carbapenem-resistant Pseudomonas aeruginosa, which is a bug that is particularly good not only at being resistant, but even if you test the isolate before the treatment with the standard tests, and it looks like the treatment you're going to administer will work because that isolate is susceptible, then Pseudomonas aeruginosa has so many ways of actually becoming resistant during the treatment. Yep. And because it has a lot of the types of resistance mutations, which can be present, for example, in a very small number of bacterial cells. So it wouldn't be picked up with the standard susceptibility testing that you would do. But once you basically hit it with the treatment, then you're killing off the majority of the bacterial cells which are susceptible, but then as long as there's a very small population of cells that just happen to be resistant, just because they happen to have those mutations, then basically they are able to amplify, and you get this regrowth which is resistant, and basically the situation being worse than before. And also what we've been looking at is that these bugs can do this also for our newest approved antibiotics as well, which then, just brings it back in with the loop how it's really important to do the dose optimization and to, basically try and foresee this resistance development and find those ways of dosing the antibiotics in order to suppress this as much as possible.
Okay, yeah. I think, like I wanted to say, like with the Pseudomonas resistance, it's almost hiding in plain sight, but hopefully you can't see the growth when a patient does get it. So it's a really good example you bring up there of antimicrobial resistance. But of course, I want to say I think my favourite example is just your classic MRSA. I'm always terrified that I have it the amount of time I spend in the hospital. But that being said, I don't pick my nose at work. So hopefully I'm okay. And of course, that's a nightmare to decolonise. I remember doing my microbiology units before I started studying pharmacy, and my TA at the time said, and this is maybe 4 or 5 years ago now, but my TA at the time said, our nurses, doctors, healthcare professionals used to have to test whether they were colonised for it or not. And when they did test positive, they had to do the whole decolonisation protocol here in Victoria, which, meant they had to take a couple of weeks off. And unfortunately, they stopped that because, of course, everyone got it. It spread so prolifically that no one was coming to work. So they've stopped that now, which is a bit scary. But I think inevitably, it's just one of those examples. It's difficult to overcome. It's prolific. It's coming into the community now, I think. We're seeing MRSA like community-acquired pneumonia almost. I think I've been learning about antimicrobial resistance for the last 5 years or so, but hearing the examples and just how terrifying it can be, especially when you're hearing things that are evolving in front of our eyes, because of course the bacteria just evolve constantly. They love to do that, unfortunately. But I suppose moving on, talking about risk of antimicrobial resistance and it emerging in the community, I'm not sure both of you are probably aware, but recently it was written into legislation that pharmacists can now prescribe antimicrobials short courses for uncomplicated UTIs, as I mentioned before. And I suppose I was curious to get both of your opinions on whether or not this is, something that, whilst it is very beneficial to the pharmacy profession and letting us practice to the top of our scope, do you think there is a possible detriment that might emerge from the more available use of antimicrobials in the community? But that being said, I think I wouldn't mind starting by answering this question and saying that from my experience in the community, I'm seeing a lot of inappropriately prescribed antibiotics. And so I wouldn't be surprised if this almost balances it out, but I'm hoping it makes the situation a bit better. So maybe Nikhil, what were your thoughts on that?
Yeah, I'll preface this by saying I work in hospital, so I'm very outside of the primary care space, and I know I wasn't actually even aware that other states have legislated it now. Last I'd heard it, Queensland, I think.
I think it's Queensland, New South Wales, Victoria.
Yeah.
But I think the others are left out at the moment.
Yeah. Okay. I think it's just important to, I guess, have a balanced view, right? Like it's both. It's an opportunity and it could be a detriment. So it's an opportunity in a sense that, I think it only applies to women who have uncomplicated cystitis. But that's a cohort that we very often get this infection. Though it's generally self-limiting, its impact on quality of life is big. And just removing that barrier to have to go to a GP and get a script, I think is great. But the reality also is that with increased antimicrobial use, there is generally increased resistance. We'll have to see how that plays out. We do monitor these things nationally and on state levels. So it will be interesting. And the most important thing, as you alluded to, is just making sure that use is appropriate. And I'm sure there's frameworks in place to ensure that.
Definitely.
And we'll just have to see, I think, and monitor. But I think it is a step in the right direction in terms of access to care, which is always important.
Yeah, I 110% agree. And I think the algorithm they use in the community is to make sure that the patients they are giving these antibiotics to, it does really narrow it down. And hopefully it does actually introduce a bit of improvement in practice. But it's important that we recognise that it is state specific. Different states will have different legislations. For example, when I was in Central Australia, they couldn't dream of doing it at the moment. They might be in the pilot stage soon, but they can't legally do that education. And on that note as well, in WA, from memory at least, they have prolific resistance against cefalexin in their E. coli. So that's not even an option for them, which is at the moment, I think it's their third line, maybe.
Yeah. I think that's changed to third line now.
But yeah, I'm curious, Cornelia, what your thoughts coming out of, from a laboratory perspective and even an academic perspective, outside of clinical practice, what do you see is this an opportunity, or do you think introducing better access might have some long-term consequences?
Yes, I think from the pharmacist perspective, it's an opportunity for more education. Maybe there's more interaction with the patient in that sense, and I think that's really important. I think for the patients to understand, how do they need to take it and why. I think that's something where pharmacists can make a really positive impact. That's really required. And in terms of the pharmacological and antimicrobial resistance aspects, I think I can only agree with what Nikhil has said, that it's important to be narrowed down with very specific criteria on those prescriptions. Just to make sure that we get the balance right on that.
100%. I think I'm just reflecting now, actually, because with this pilot program, of course, it's a private prescription when it's given through the pharmacist as well.
Right.
Which I thought would be good to mention because, of course, now nitrofurantoin being the first line agent and probably the one that's recommended for this pilot program now, assuming the software's up to date now, it's quite expensive as a private prescription. So it's introducing another barrier, I think. So hopefully we can allow the pharmacists to get a bit more advocacy in making this more accessible and cost friendly. Because I know especially out in those remote communities where the pharmacist is their only health practitioner within an hour or 2 hours drive, I think it's really important, like you said, Cornelia, education. Education is key. And I think it's important that the pharmacist is educated to be able to give that good education.
Absolutely.
And I suppose moving on, talking about antimicrobial resistance in the community, maybe Cornelia, I'm curious, from your perspective and your knowledge of antimicrobial resistance, what are some things I could do or any of our listeners could do in the community to help prevent antimicrobial resistance becoming too prolific and too big an issue before we have to move all the way to using polymyxins as a first line?
Yes, that would be an absolute nightmare, using polymyxins. One main thing is to basically be aware about when antibiotics, 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 Yeah, for certain conditions, like viral colds, obviously there's no point in, maybe requesting an antibiotic treatment. So, I mean, that's one of the very obvious things.
I've had too many people coming up to me like, oh, I've got the flu and the doctor won't give me amoxicillin. I'm like, how do you know what amoxicillin is? But yeah, I think that's such a good point. I think there needs to be better education, because personally I grew up not getting this kind of education. Like I can remember now as a kid getting, the amoxicillin syrup because I had a cough. Whether I had any microbiology susceptibility testing done, probably not. But, the GP was happy to satisfy my mum, give me the script and get out of the office. So I think it's a really good point. And maybe Nikhil, especially managing so many immunocompromised patients, I'm sure you have a plethora of tips.
Yeah, I think, there are many. But I think just sort of jumping off Cornelia's point in sort of a primary care setting where, the large majority of the population obviously is, debunking myths. Like, you don't need antibiotics for viral infection. Yes, viral infections make you feel terrible, but they go away on their own.
Yes.
The other one that I think is probably still a myth that runs around, it was definitely when I worked in primary care, which was a long time ago now, but is you have to finish the course. There's a magical number, like if you finish the box, then the bacteria know that they can't develop resistance. That's obviously not true. More antibiotics means more resistance. We just need to treat enough until you can get better.
Yeah.
And we have guidelines like Cornelia alluded to, is like familiarizing yourself with these guidelines before you prescribe, or even as a pharmacist dispensing, like, is this the right duration? Because we're just getting so much evidence now to suggest that shorter is equivalent to longer. We just need to start having some confidence in the science.
And I think that runs all the way from the community to the clinical side. Duration is key, and the number of scripts I've seen without durations on antibiotics, I couldn't count on my two hands alone. Especially working in community, it's the classic, you get a script for a box of amoxicillin, TDS, and that might be 6 2/3 of a day. And I'm like, okay. Someone obviously hasn't read their guidelines recently. But that being said, I can obviously empathize where, I can get that script, but in the fast-paced environment of community pharmacy, I don't have time to make that call, get them to write a new script with a correct quantity. And legally, I can't change the quantity. So I can deliver that counselling, but then, if I'm going to give someone a 5-day course, they have another 5 capsules of amoxicillin sitting in their bench. And I can tell them, you know, bring it back to the pharmacy. I can get rid of it in the rum bin. Are they going to come back? No, no, they are not. They do not want to be back in there. But yeah, I thank you so much for those tips. I think my tip is just, you know, make sure you wash your hands. Oh my God.
That was a big one, very big one.
Yes, please, with soap, not just water. And I suppose moving on, kind of going back here, I'm in my early career. You guys, Nikhil, you're more early-ish career, and Cornelia, associate professor, you're in your early career as well. Let's say that. Yeah. We're all in different stages here, and I think personally I've done some work in research as well. Unfortunately, not in infectious diseases yet. But I suppose I just kind of wanted to pose the question as, Cornelia, maybe you can answer on this one first, is you've completed your PhD a bit back now, and I suppose where has your real research led you now? Because you're here at MIPS, you're working with Queensland as well. I suppose it's a good moment of reflection of how far you've come, and I suppose maybe do you want to tell us a bit about how you've come from your PhD to where you are now? What was your career pathway along? I know I've learned recently, life just throws us curveballs all the times. So I'm curious to how you got to this table here today.
Yeah.
And don't say up the stairs.
No, and I, totally agree with your comment that, I just want to say at first, I think it's important to always be open to opportunities because at least in my view, I probably couldn't have planned it in the way, to be perfectly honest. So I actually did study pharmacy in Germany. Then I did a pre-registration training at half a year in London, in Charing Cross Hospital in London. And that was in the clinical pharmacy space. And that's really where I got the idea to say, okay, can I do research, learn how to do research in order to come up with better ways of, dosing for patients. So that's where it actually did start, in a clinical practice setting. Therefore, I did a PhD in Germany, which was on pharmacokinetics of antibiotics with patient studies, actually, PK studies, and then did that and went to UQ for half a year in order to learn about mathematical modeling because, at the time there was a group there doing that. Then I also went to Albany, New York in the US, where they are doing some of those laboratory models I was talking about, laboratory experiments and more mathematical modeling. Went back to Germany to finish my PhD. Then there was an opportunity in Buffalo, New York in the US. With the group of Professor William Chesko, who is one of the basically pioneers of really pharmacokinetic pharmacodynamic modeling and what we call mechanism-based modeling. Learned more about modeling there, went to work in a research institute in Albany, New York, doing both the modeling in a CRO setting, so basically contract research organization helping pharmaceutical companies in their development of antimicrobials, as well as, linking with the lab side of things in the research institute. An opportunity became available here at MIPS because there was the group of Professor Roger Nation at the time and Jian Li, who are, doing a lot of work in polymyxins, of course. They were basically looking for capability really in mathematical modeling to help this the PKPD efforts, and then, moved back around the world. Did a lot of industry work, a NHMRC fellowship, so that's like where you do research in a fellowship setting, and I was able to build a research group and then moved to a teaching and research position. So as I said, I think it's good to think about what is it you would like to do in your career? And then sort of, I guess try to be prepared for opportunities.
Oh my God. I haven't even registered as a pharmacist yet, and just seeing how much you've traveled, it's like, I'm excited for my career now. Oh, wow. I'm almost overwhelmed with just how much you've done. And I know for a fact from my undergraduate, it was funny you mentioned Lee's work in the polymyxins because I had to write an article on one of their papers 2 or 3 years ago. And I distinctly remember their work in novel polymyxins, and which is why I remember 18 months ago or so, the first time I had Nikhil lecturing, I of course posed a question about polymyxins to him. So it's stuck in my mind because that assessment was traumatic.
I apologise.
No. Your question was fantastic. You answered it well. And I suppose, like, Nikhil, I'm curious because I remember you telling me about your career, but for the listeners, let's recap it.
Listening to Cornelia's story, mine is not as exciting at all. In fact, I would say it's the complete opposite. I have stayed in Parkville my entire career. Studied at Monash University, went to the Royal Melbourne, went to the National Centre of Antimicrobial Stewardship, which is at the Doherty, 20 metres across the road, then 20 metres across the road to Peter Mac. So I'm a homebody, obviously, but anyway, when it comes to research, honestly, I didn't see a career in research for myself when I started pharmacy. I was very clinically focused, and I had the impression throughout the first maybe 7-8 years of being a pharmacist that you can be an excellent clinician without necessarily being an excellent researcher or even a researcher at all, which I think is still true.
Yeah.
But I think as to be an excellent clinician, you at least need to understand research.
Yeah.
Even if you're not going to do it, you need to understand how to interpret evidence so you can apply that. And the more I began to understand research, the more I was like, I think it would be nice to do this and, have a question, go about making a methodology to answer said question and coming out with an answer.
Yeah.
And I just got pretty lucky, I would say, in my career. Like, I think just being a very, keen pharmacist who spent a lot of time trying to learn stuff clinically, attend as many sort of medical education things, ward rounds, stuff like that, that I just became quite known to certain consultants and professors within the unit who then, going back to what Cornelia said, gave opportunities that initially, I hesitated on, but then I think I've learned that you should try and say yes to things, and be prepared for when things could have come out of the blue, which they do inevitably, and just saying yes. And the particular professor that I work with now, Karen Thursky, gave me opportunities to work with her in different capacities, which eventually led me to work at the National Centre of Infections in Cancer doing a PhD, and she is one of my supervisors. So that's kind of how I landed there, and I'm only a couple of months into my PhD now, but it is exciting.
Yeah, and it's really good to see both of you have really taken on these opportunities, because I know myself, I went into pharmacy maybe a year and a half ago now, and I went in thinking, I want to do like hematology, oncology, because that was what I enjoyed in my biomed degree. And then 6 months later, I just asked one of my supervisors, got nothing on during the winter. Do you have anything, research projects I can get up to? And I was just like, I just got to take the opportunities as they come. And because of that, I've been involved in maybe like 6 plus research projects now, because it's just kind of come one after another. And I was in Sydney last week at the Lifelong Learning in Pharmacy conference, and I'd already known half the people there because they'd seen my work, they'd seen me present at other conferences, and it's all because I went out of my way to ask and take that opportunity. And that was, a year ago now. And I can see how much I've changed and how much I can reflect, and really wish that, I myself a year ago could see me now. Because I wouldn't think I'd be sitting at this table with two of the greatest ID practitioners and researchers that I know, and probably working in Parkville. Obviously, you've been in Parkville the whole time, and hopefully you're here to stay. I won't tell MIPS if you need to leave. No. But I suppose moving on now, I think just kind of wanted to wrap it up on this note, because I think we've had a really good discussion today, and I want to kind of bring it back, and I want to almost pose a personal question where, unfortunately, I haven't had much experience in infectious disease patients. I've seen them. I was in the ICU at the Alfred for 2 weeks, and I have seen some of those funky bugs come up, and I was lucky enough to see it in the US. But I suppose, what are 2 key pieces of advice outside of taking opportunities as they come for someone really interested in infectious diseases, pharmacy students or pharmaceutical science students? Nikhil, maybe you can start us off. What's one key piece of advice or somewhere we can go to really harness this passion and, like you said, hopefully one day become the future pharmacists that have these really specific interests and specializations in things like CMV and antifungal microbials?
I think probably 2 things that are pretty similar.
Yeah.
Would be, if you really set on infectious diseases and, it's something you want to explore further, don't wait for opportunities to fall into your lap necessarily. You can go find them. Yes. I think if you if you follow sort of different professional organisations on social media, sign up to email lists, read the newsletters, opportunities just everywhere, and it really is just up to you to sort of just put your hand up and be like, hey, I might just throw my hat in the ring for this one.
Yeah.
You know, the worst thing that happens is that, you know, you don't get that particular opportunity, but then you're earmarked for maybe something else that pops up. You're on someone's radar.
Yeah.
So I guess, putting your hand up, finding a mentor if you have access to one.
Yes.
Like if you're already, students might be a bit harder, but like you probably might have people within Monash or Cornelia potentially,
Yes.
who work in that space and might, you know, people of Cornelia's caliber, professors and things, they always have projects that need someone to work on them. There's busting at the seams with ideas. They just, So opportunities are there. Just a matter of having the confidence to maybe go do something about it.
Yeah, I agree. The free labour of students can definitely benefit both parties. I know a lot of the research I've done has benefited me, and, you know, obviously helping push those publications through is a goal for a lot of people that want to go into research or have that interest in research. But yeah, I think that's a really good point. And I know for pharmacy students specifically, for example, ADFA, well, SHPA, formerly known as SHPA, ADFA do their summer placements at Peter Mac as well. So I know they do those, I think they were 4 weeks or 3 weeks. I can't remember now.
Sure.
But yeah, so that's one opportunity that people can put their hand up for if they're not savvy to going out of their comfort zone. And I know there's some really great opportunities to do work with them over the summer. And that's a paid placement too. Not endorsing it, but but I know it's a great opportunity. And I suppose on the other side, here at Parkville, we have pharmacy students. We have pharmaceutical science students. We don't collaborate with one another as much as we should. But that being said, pitching towards the pharmaceutical science students, perhaps, do you have any words of advice for people that really want to go into infectious diseases research and antimicrobial research? Because I know for a fact that making new antimicrobials in that research is it's a challenge. It's a challenge because you can't put a new drug onto market when you've got something that works just as well, hey? So I suppose what are some advice you can give to students that are really wanting to go into where you are now?
Yeah, I mean, I think one main thing is to look at the research placement projects that students can do in third year.
Yeah.
And so there are different efforts in the area of infectious diseases, antimicrobial resistance, which there are research programs in medicinal chemistry, which is more on the, basically discovering of new agents and really the chemistry side. And then there is, our PKPD laboratory experimental work, mathematical modeling work. So we've had a lot of those placement students come through our lab and also pleasingly, continue to honors and PhD and even postdoc. I think just, looking at those projects, talking to potential supervisors.
Yeah.
And then there's also, there are also those summer and winter scholarships as well. There can be an opportunity which is paid. And that can be an opportunity as well to just see how a lab is working and what's the type of research they are doing. And, don't be afraid to, for example, talk to your lecturers after the class. Usually, researchers and lecturers, they like to talk about what we are doing, right? So, don't be shy, I guess.
Yeah. I can definitely, I want to echo that. It's really important. Really go talk to your lecturers at the end of that lecture. Don't just leave. They love to have a chat. I know I've gotten into at least 2 research projects just by approaching my lecturers after class because they're like, oh, no one else wants to talk to me. So, how you going, Jack? Yeah, that's a really good point. And I think as well as, Nikhil's only just recently started his PhD, but he's been in pharmacy for at least a decade now, right? So I think that advice can not just apply to the students here at Parkville, but practicing pharmacists that, there's a lot of pharmacists out there that are in the interest of infectious diseases. And I know there's a bit of a challenge to get into the workforce with that in a lot of these hospitals at the moment. So maybe there is a space there for these pharmacists to come doing the research as well. I think we need all hands on deck to challenge the challenges of antimicrobial resistance as well. And I think pharmacists with their medicinal knowledge and, as I was reflecting before, our care for patients, we can bring such a great workforce into the field of research in antimicrobial resistance, pharmacokinetics, dynamics, etc. And I suppose before we finish off, and before I thank you for coming in, I just want to ask, do you have any final thoughts? Anything you wanted to let our audience know?
Nothing particular for me.
Yeah, perfect. I think I've asked plenty of you guys today, so I'm really appreciative. Cornelia, yeah.
Yeah, I think it's a really scary thought, I think, about antimicrobial resistance, right? A lot of the time when we see those statistics.
Yes.
It's also an exciting time because of all of those new, efforts are coming out. Like Nikhil mentioned, the model-informed precision dosing.
Yeah.
And also, I'd like to mention rapid diagnostics for bacteria, for example,
yes.
that are being rolled out in the clinic, where we can find out about the characteristics of the bacteria in a short time.
Yep.
So I think, one really exciting thing, if we could do, which, involves a lot of the interdisciplinary collaboration, is basically to link these things together.
Yep.
With, model-informed precision dosing, typically it's considered to adjust the dosing to the patient characteristics.
Correct.
And, linking the bug characteristics into that, and then having this really interdisciplinary effort between clinicians, researchers, microbiologists. I find an exciting prospect.
It is.
Yeah, I think a lot of discussions between student groups, at least personally, a lot of this interprofessional idea is, we're going to go have classes for the nurses, we're going to have classes for the medical students. But I think we bring up a good point. We need more focus on that interdisciplinary connection between microbiologists, the people doing the groundwork, the people working in the wards, but as well as people working in the labs. And I think that connection is somewhere that's being missed at the moment, at least in my education. But I hope to see it's becoming better, and I can hope it's coming better a bit. Nikhil, yourself, you're doing both jobs at the moment, almost. But yeah, I hope that these kind of discussions can bring all of these people together, because I think, now's a really important time to challenge antimicrobial resistance. Like I said, it's exciting, it's scary, but it's exciting. We have a lot of people, there's, the research is coming out as a breakneck speed, not as quickly as AI, unfortunately, but that being said, I'm sure there's a space for AI in this, who knows? Yeah.
I think so.
Especially in, AUC modelling,
Yeah, I think it's already
being used, eh?
Yeah.
That's cool.
It is pretty cool.
Yeah. But yeah, I want to thank you both so much for sitting down and have a chat with me today. And yeah, that's all for us today. Thank you so much for joining us.
Dosage Pharma acknowledges the traditional custodians of the various lands throughout Australia on which we connect today, and pays respect to elders past, present, and future.